Let's get going here. All right. Good afternoon, everybody. Welcome back to another NGSBA webinar. My name is Michael Quedal, Quality Controls for the New Jersey School Boards Association, and thank you so much for joining us today as we talk about today's topic, unpacking the surge in health insurance claims costs. The rising cost of health insurance claims are increasingly driven by weight loss and specialty medications. But what's really happening behind the scenes? One thing that's impacting it is weight loss medications. These drugs, often prescribed for obesity management, are becoming more popular. While they can be effective, they're also very expensive, contributing significantly to insurance claims. And specialty medications we're also be getting into, and how those high cost drugs are used to treat complex conditions like cancer, rheumatoid arthritis, and many other things. So we're definitely going to get into a lot of information today. I want to let everyone know that this webinar does offer one BMA credit, one board member academy credit. So for all of those who are in this meeting room and stay for the duration of the presentation, we'll have that reflected on your transcript. Just give us a couple business days, as always, due to it being a manual process on our end. A couple things regarding Zoom features really quickly. Towards the right side of your buttons, you will see the CC button as your closed captioning functionality. If you click that, it will allow you to view the closed captioning of this session. You'll also be able to view and save the entire transcript of the session if you need it. The Q&A function is turned on, so we do ask if you have any questions whatsoever, please drop it in the Q&A box. It just gives us a little better way of organizing the questions coming in. The chat is also turned on, so if you want to drop us a comment, say hi, tell us where you're from. We love hearing from you, so please use the chat function for that. Attendees of this webinar should be aware that the views expressed by non-NGSBA employees and outside speakers or panels are intended purely for informational purposes and do not necessarily represent the views, opinions, or mission of the New Jersey School Boards Association. NGSBA remains committed to providing nonpartisan and apolitical information, resources, and advocacy to advance public education and promote achievement of all students through effective governance. I also want to say this really quickly. We do rely on our partners who are out in the field, who are out in the district. You may be working with someone else. You may be working or have a vendor who's currently on this call. That is totally fine. Either is totally fine. This webinar is for informational purposes to help you make more informed decisions in your district and at the board table. Finally, this session is being recorded and will be available through NGSBA's website. So under the trainings tab, click webinars. That's where you'll see this webinar recording later today, along with all of our previous recordings, along with a lot of great webinars upcoming as well. And the slide deck will also be posted on the SWUGO site. However, everyone came in here to the webinar live here today will be posted as a resource as well. So without further ado, it is now my pleasure to introduce Lou Della Penna Jr., Executive Vice President for Brown and Brown. Good afternoon, Lou.
Good afternoon, Michael, and good afternoon, everyone. We really appreciate you joining us here today. So my comments will be brief, but I would like to give you just a little background. I began working with New Jersey school districts in the employee benefit area on March 1st, 1989. Yes, that equates to 36 years I've been working with school districts around health insurance, prescription drug insurance is what we're going to really focus on today, dental insurance, et cetera, et cetera. And over that time, obviously, we have seen a lot. A lot of things have changed over those years, and I wish I could tell you what a family rate might have looked like with prescription drug insurance in 1989 or 90, but I'm telling you, it was likely something under $100 back then. And now we look at it today, $1,000 or more. There's obviously been sharp increases in utilization and expenses. So Brown and Brown, the company I'm a part of, is the benefit broker consultant to over half New Jersey school districts. So once again, we've pretty much seen it all. And this particular topic, just to give you sort of my take on at least my interest in how I got started, trying to understand what's going on with these weight loss medications. Now, by the way, just before I get to that, um, it drives me nuts when I'm in business meetings and people talk in acronyms, and I don't know what the acronym means. So, but sometimes it happens, and if it happens here, we apologize in advance. But the one acronym that I want to make sure you understand what it is this GLP-1. That is the acronym for the weight loss medications we're going to talk about, and the experts that we have here today will really dive into that. But for me, how this all started was not from a perspective of advising our clients and that sort of thing. It was really human interest. I first heard about this having a very dear friend who is a diabetic who started taking Ozempic, and I really didn't have a sense of what that all meant, but I did watch this person lose an awful lot of weight. And so a number of years ago, I happened to attend a conference with an insurance company, and they had someone from their pharmacy department there and talking about these GLP-1 weight loss drugs. So I'm like, I better start taking some notes and try to understand, because I think more and more people are that around me on a personal level might start having interest in these drugs. And so that's how I got started. And then we start seeing what's going on and the impact on our clients' costs around utilization, whether it be right now for weight loss or for diabetes. It's like, whoa, we got something really crazy happening. And from my end, I think this train does not have a break right now. So, and the gentlemen that are with me today will really explain that more closely. So, once again, it started for me as a human interest thing. I am sure that everyone that's in this meeting right now or going to watch or listen knows somebody that has either taken weight loss medication or is interested in getting weight loss medication. The other thing that I would ask all of you to pay special attention to, so as we all have fiduciary responsibilities around the cost of these programs, whether it's prescription or anything else, we always ask our clients to remember we're also consumers of healthcare. So as you hear things about this, there's going to be little flags that go up when you hear about some of the things in the pipeline around weight loss medication that are just waiting to be approved. And so right now it's weight loss and it's diabetes. But imagine a time where weight loss medication can be prescribed for sleep apnea, as an example, which is one of the ones out there. So pay special attention to that. So at this point, I want to introduce Joe Champa, who's a director of public sector business at Horizon Blue Cross. I've known Joe for many, many years. We worked on a lot of these various issues in the past, and then he will introduce the team that we have who are the experts in this field. So, Joe.
Yeah, thank you, Lou. Appreciate it, and very happy to be here. Good afternoon, everybody. It's good to see a couple of familiar groups in the chat that are customers of Horizon Blue Cross and Blue Shield. So I'm very happy to be here and very happy to be joining Lou and the NJSBA as well to talk about really what is top of mind for a lot of folks, as Lou kind of alluded to. When I started in this business, and I'm not quite as tenured as Lou, but I'm pretty close. But in the mid 90s, when I first started getting into working with groups in the public sector, the percentage of total cost for benefits, prescription drugs probably made up somewhere between 15 and 18% of the total cost. This is back in the 1990s. Now, as I know our subject matter experts from Horizon will tell you, that number is probably well over 30%. So whatever your boards and your groups are spending on their health benefits, that's prescription, medical, dental, vision, what have you, over 30% of that is probably going towards prescription drugs. So that, even over this long period of time, is substantial. So I didn't want to talk too much. Luckily, you won't have to hear my voice too often, but I do want to introduce Michael Healy and Timothy O'Shea, and they've been with Horizon for several years, and they are the subject matter experts in terms of what we're doing and what we're seeing as trends go in the prescription industry. They have a lot of great information to share with you. I would encourage folks to ask questions through the chat, and we could certainly answer those as we go along, or we can answer some of those at the end. But again, very happy to be here and very happy to be introducing Michael and Timothy.
Thanks, Joe. Yep, Mike Healy. I'm the Director of Pharmacy Business Strategy here at Horizon, and I'm responsible for new sales and client retention as it relates to pharmacy. And with us is Tim O'Shea. He's going to be the star of the show today and doing most of the talking. Tim?
Great, thanks, Mike. So Timothy O'Shea, Director, Specialty Pharmacy at Horizon. Been with Horizon for around 10 years, and pharmacist by background. And really going to go through really some of the big things that we're seeing within pharmacy today. And that being said, I think we can jump right in. The agenda today is listed, so we're going to focus on a couple topics. One is going to be GLP-1 drugs. As mentioned, these are drugs that originally used for diabetes and over the course of time have had some expanded indications, so also have use in for weight loss, and talk about the other indications for cardiovascular disease and sleep apnea. We'll go over some of the things that we're seeing in the data. I'll relate some of the things that we're seeing in the Horizon data and kind of in relation into the national trends of these drugs. And then we'll focus on some specialty drug trends, again, some of the things from a landscape and industry perspective that we're seeing, and then the role of biosimilar drugs. So if you've never heard of biosimilars, we'll talk more about what these are and the role that they play. So I'm going to really start at the highest level view of looking at what are the challenges, what are the opportunities in the world of pharmacy today? Like these are the 6 biggest things going on in pharmacy today. And we'll focus on some of these in the interest of time. We won't cover all of these, but these are really like the biggest things going on in pharmacy today. If I start in the bottom left with the Inflation Reduction Act, again, we're not going to talk about that today too much. That could be a whole separate conversation, but we know there's a lot of legislative changes going on that are impacting what we do within pharmacy. The Inflation Reduction Act, which was signed in 2022, had some positive things in terms of limiting out-of-pocket costs for Medicare enrollees, allowing CMS to negotiate drug pricing. I'd say the really true net impact of that, probably TBD, still a little bit early, but we know there's impacts there. Drug shortages are real. We see them all the time, not just in the retail pharmacies, also in the hospital pharmacies as well. Lots of reasons why there's drug shortages, from just shortages of raw ingredients to make the drugs, from natural disasters, hurricanes in just Puerto Rico several years ago had large impacts in terms of IV fluids and other drugs, North Carolina and others where there's been some natural disasters really, and has had big impacts on the drug supply chain. Where we will focus, though, is more on the specialty drug pipeline and trend. And so you can see the specialty category, we'll talk more about this, accounts for just 2% of all drug fills by volume, but over 50% of RX or drug spend. So relatively low utilization, but just by nature, these being high-cost drugs, half of what's being spent on prescription drugs. Biosimilars, we'll talk about. A lot of things are really increasing costs within pharmacy and healthcare. Biosimilars are one where this is actually offering cost relief, which is a good thing. GLP-1 drugs, that's really going to be the bulk of our discussion today. We're seeing huge growth in the number of prescriptions. So you can see GLP-1 prescriptions in 2023 is 55 million. That's 3 times from 2020. And a robust pipeline. We'll talk more about that. We're really, if you could believe it, in the early stages of use of these GLP-1 drugs, then will be in the next 3 to 4 years. And lastly, pharmacy store closures. It's a big one. There's challenges on the pharmacy end, reimbursement, staffing challenges. The number of independent pharmacies has been drastically decreasing over the past decade. And we've seen and heard announcements from some of the major retail pharmacies saying that they're going to close in a certain number of stores over the next few years. So that's led to nearly 1 in 3 retail pharmacies having closed since 2010. Really, though, the focus of what we want to cover are what's listed in red. That's exactly what we're going to cover first with GLP-1s, and then specialty drugs and biosimilars. So I'll start with the GLP-1 drugs and GLP-1 drug trend. And GLP-1s are a class of drugs. These are glucagon-like 1 peptides, agonists. We'll call them GLP-1s, for short. And it's interesting, and probably everyone's heard of Ozempic. If just in terms of seeing the advertisements and Wegovy, and there's a lot of advertisements, a lot in social media. And originally we had GLP-1s, and we'll show the list of drugs in the next slide. For type 2 diabetes, we've seen them, some for weight loss, some for cardiovascular disease, some for sleep apnea. The benefits of therapy are, what I would categorize this as saying is that these are really effective drugs. Like these work really, really well. For those with type 2 diabetes, these are a first-line drug therapy for many diabetics. And they work really well. They control sugar levels. It controls your A1C levels, which are kind of a long-term measure of diabetic control. Has a lower risk of hypoglycemia or low blood sugar than some of the older drugs for diabetes. It has benefits in terms of cardiovascular and renal benefits, and also weight losses can be beneficial in those with diabetes. From a weight loss perspective, they work really well too. It work by slowing your gastric emptying. It decreases the desires for food, and they, the studies and the data shows pretty universally they work pretty well. There are some concerns with these, and those are the benefits of therapy. If you look at the other side of the slide on the concerns, the data shows that about half of people will have some type of GI side effect and some type of gastrointestinal side effect, and that could be mild for some and significant, severe for others. There is an increased risk. It is low. To be clear, it is low, but there is an increased risk, at least the data would tell us, of thyroid cancer and pancreatitis with chronic use of these products. We see high dropout rates. I'll show that in a couple slides of some of the things that we see in the data. There's lots of reasons of why someone may discontinue or stop taking their GLP-1 drug. It could be that they're having side effects, or it could be there's been shortages of some of these products, or could be due to cost, out-of-pocket costs as well. But we do see high dropout rates. And the concerns ultimately come around affordability. So it's important, affordability for patients, employers, and payers. The average cost for a GLP-1 drug is about $1,000 per month. Depending on the drug we're talking about, that could be $1,200, $1,300 a month. So per year, I mean, we're almost at $18,000, 15 or so $1,000 a year, up to 15,000. So they're high cost drugs. And so, balancing the, really ensuring the proper use of these drugs are going to be critical. So I want to talk about the commercially available GLP-1 drugs. And again, I mentioned Ozempic, and some of these newer ones you probably have heard of, or at least seen the advertisements for, Mounjaro, Zepbound. And it's kind of, as I noted earlier, it's interesting because, we've had GLP-1 drugs since 2005, but it's just really in the past handful of years, there's been this huge surge in terms of what we see in our data, and the national data shows in terms of the use of these drugs. Use in, so, mentions in social media have increased more recently. And so you might think, well, these drugs have been available for, 2 decades now. But why is this just now gaining attention? And there's a few reasons for that. Predominantly, though, the fact that some of those earlier GLP-1 drugs like Byetta and Victoza, they weren't quite as effective in terms of diabetic control. But they also had to be, these are all injections, minus you have a one oral product for Belsus. But most of these, the early ones, it was a daily injection, or in the case of Byetta, a twice daily injection, right? Not going to be super convenient, not going to be good from an adherence perspective. It was later on, really with Ozempic in 2017, where we had this now weekly injection, and Mounjaro in 2022 as a weekly injection. Fast forward a little bit for weight loss. Again, we had one product, Saxenda, in 2014 for weight loss. It wasn't the best from an efficacy perspective. Didn't have quite some of the benefits in weight loss that some of the newer ones have shown. It was also daily injection. Again, that's not going to be great from a convenience or persistency perspective. Wegovy, approved in 2021, was a big one. Zepbound in 2023, a big one. These are going to be specifically indicated for weight loss, and we'll talk about some of the criteria and who may qualify for these treatments. Just looking at some of the aggregated view of some of the clinical policies out there by payers. And then furthering the evolution of GLP-1 drugs, Wegovy had an expanded indication for cardiovascular disease last year. And then Zepbound had one at the end of last year for sleep apnea. So, and we'll talk about some of the future indications that could be coming over the next 3 to 4 years as well with these class of drugs. So I'll talk about Horizon utilization for these. This is Horizon data, but this mirrors the national data quite closely. And the numbers are not so important, in terms of whether it's, this million or that million. But what you can see here is, just from a trend perspective, like we can see pretty evidently from 2022 to 2024, we've seen big increases. And so since 2022, we've processed over 370,000 claims for GLP-1 drugs for over 46,000 members. But use in both diabetes and weight loss is increasing. So diabetes in blue going back from 2022 to 2024, right? That's a clear straight line up in terms of growth. Same for weight loss. We can see in 2022, right, $8 million in spend, increasing all the way to $52 million in 2024. Again, the numbers, obviously, that's Horizon data, but the trends that we're seeing as a percentage of increase, that mirrors national data as well. They're just nationally seeing big increases in the use of these drugs for lots of reasons, but again, would characterize these drugs as being really effective. They work really well. They're just kind of costly, and they have some side effects. One of the interesting things that the Horizon data, when we look at our data that we've seen, and again, this is very similar to what the national data shows, is that we looked at our data in those that have filled a GLP-1 drug. This is looking specifically for weight loss, and we looked at the natural course of the fill history over the course of 12 to 18 months to say, what was the adherence for these drugs? And of course, at month one, everyone fills and everyone's adherent. But at 1 year, 70% of patients were not taking a GLP-1 drug. 60% of people that discontinued did so before 3 months, which is pretty notable. Now, discontinuing for a GLP-1 drug for weight loss, from our data, right, we see that the claim's not filled. Could be lots of reasons why that's the case. It could just be due to, it could be due to side effects. It could be due to out-of-pocket costs for being too expensive. Or it could be the fact that maybe at month 12, you were on a GLP-1 drug, you lost 40, 50 pounds, and then you're going to stop the drug and maybe manage through lifestyle. And that's pretty reasonable. And we see that quite a bit. So the reasons of why people are discontinuing, not as apparent here, but we do see kind of that natural decrease over time, which I think is interesting. We'll talk more about what some of the data is showing in terms of the long-term data for these products. Like, do they lead to cost offsets? Are people healthier in the long run? We'll get to that in just a minute. And again, if there's any questions, I have it on my other screen. Feel free to ask questions as we go. So I'll kind of transition into the coverage and management. Again, this is not necessarily like how Horizon is covering and managing these. These are really the industry standard programs that you'll see around GLP-1 drugs. And so, for the most part, the benefit coverage is gonna vary. So when we're talking about a GLP-1 drug, usually the first question people may have, if you're a consumer, you're a patient, and you get a prescription, or you're talking to your doctor about GLP-1 drugs, is, are these even covered? Right? It probably heard a lot about people trying to get a GLP-1 drug, and it not being covered. So what I would say here is that for diabetes, cardiovascular disease, sleep apnea, right? These are FDA approved indications. For diabetes, it's a first line drug, right? There's going to be benefit coverage, really across the board for these products. It's really when you get into weight loss where you're going to see some differences here. And so from a Medicare, Medicaid perspective, again, just some of this is informational. Medicare does not cover weight loss drugs today. That could change. There's some things that are in discussion. But Medicare, these are not covered. For Medicaid, these are only covered in those less than 21 years old. There's still policy criteria, and I'll show that on the next 2 slides of what some of the criteria may look like for these from a clinical perspective. If you have insurance through the marketplace, again, these are not going to be covered. And then if you just have commercial coverage, it's going to depend. So for most insured business groups, these are not going to be covered, public sector groups being the exception. And for self-insured groups are going to opt in. So can't give a one size fits all in terms of, right, who has it, who doesn't. It's going to vary in terms of whether these are a covered benefit or not. One of the aspects of management, so we have to think, well, okay, well, is the benefit there for weight loss? If you're trying to get a drug, is it a covered benefit? Right, that's going to be kind of specific for group by group. The clinical management, though, is really designed to say, how do we get these drugs? They're very expensive, but how do we get these drugs that are expensive but also very effective, really in the right patient to the right patients? And we'll talk about that in this slide and the next slide. to ensure that we're matching that up. And so it goes across a handful of a spectrum here, from saying, use of prior authorization is going to be really step one to ensure that these patients are getting to the right drugs. There's going to be some electronic edits that go on behind the scenes. And so let's say you're a patient, when you get a prescription for Ozempic, you have type 2 diabetes. In these type of edits, what happens is you bring your Ozempic prescription to the pharmacy, let's say CVS pharmacy. They're going to process the claim. There's going to be a real-time check in the medical claim to say, does this person have a diagnosis of type 2 diabetes? It'll happen in a fraction of a second. And if it finds out, oh, well, this individual does have a diagnosis of type 2 diabetes in the medical claims, well, it's just going to pay, right? It's not going to pen for any type of authorization because, well, these are first-line drugs, right? We're not going to, typically there's not going to be any type of additional authorization requirements. If there's not, let's say it's for Ozempic, but there's no diagnosis of type 2 diabetes, well, then it would go for an authorization. That's when the pharmacist would reach out to the provider. And it could be such that maybe they're new to plan, maybe they just haven't seen their provider in a little bit. What we do know with these products is that there's also, unfortunately, a lot of off-label use, a lot of inappropriate use. You may have seen advertisements around the compounding pharmacies. You may have seen other advertisements around these products for, let's say, more cosmetic use. And so we know there's a lot of fraud, waste of use. We know there's a lot of inappropriate use. And that's where, these authorizations, the criteria are going to be critical to, ensuring that we're matching up into the correct drugs to the correct patients. The retrospective claims auditing, that are things that payers like Horizon and others are going to do behind the scenes of looking at people who are on GLP-1 drugs and assuring, kind of weeding out some of that inappropriate use. We see them from MediSpa as well, certain telemedicine providers that are high volume prescribers of GLP-1s. And sometimes it's appropriate and sometimes it's not. There's lifestyle management programs, and then there's going to be continual evaluation of the safety, efficacy of these products at P&T. P&T is a pharmacy and therapeutics committee. That's going to be an organization that all health plans, all payers are going to utilize to review drugs, to make formulary decisions on new drugs, and review on an ongoing basis, reviewing drugs like GLP-1 drugs. So we're continually looking at these drugs, looking at utilization, looking at if there's any new emerging data on these products, some of which I'll talk about. And we'll bring that to the Pharmacy and Therapeutics Committee, which consists of physicians and pharmacists and people from quality teams really working together to help manage these drugs. So I'll show here some sample utilization management criteria. This is not, necessarily prescriptive in the sense of, right, every payer, every health plan may have slightly different criteria. Typically, a lot of these criteria come from the clinical studies, but you may see some minor differences, between payer A or health plan A and health plan B, payer B. But these are just some of the general criteria that you can see. And so from a weight management perspective, and I won't read all of these, but from a weight management policy perspective, right, the first one needs to be benefit coverage, again, starting on the left. And then the BMI requirement, generally speaking, is going to be either 30 or 27 with some type of weight-related comorbidity. That comes right from the product labeling. Many of these criteria come from the product labeling, meaning how the drug was studied and approved by the FDA or the Food and Drug Administration. But it's also going to look to say, was there any prior use of some type of lifestyle modification? And then for continuation, typically approved for 6 or 12 months. And then if it's submitting a new request for continuation, was there some documented weight loss? And for diabetes, cardiovascular disease, sleep apnea, again, I won't read them, but these are the type of criteria to ensure that they are being used appropriately. So for cardiovascular disease, it's really specific for a subset of those that have cardiovascular disease and have a BMI of 27 and that are already on other antihypertensive or lipid-lowering drugs. And for sleep apnea, you're going to still have that BMI of 30. Again, much of this comes from the clinical trials for these drugs, have to have a sleep test, and you can see some of the other criteria there. So just to give a sense of like who may qualify for these drugs is covered in each of the 4 use cases here. So I'll transition a little bit into, what are the future GLP-1 impacts. Like we've seen these big increases. We know that there's some management programs. Like where do we go from here? And there's a lot of what I would say there's a lot of research being done on GLP-1 drugs. A lot of organizations across the country are studying this. And so what I put here are just two of the ones that I thought were interesting. Again, there's constant, if you just Google and look at Google News for GLP-1 drugs, it's almost like every week there's an article or two on these drugs. But one of the interesting ones that there's an organization, Prime Therapeutics, who did an analysis of GLP-1 drugs, and they looked at the data. And they had 2 years of people that were on a GLP-1 drug like Wegovy for weight loss. And they looked at what were the impacts of these GLP-1 drugs. Because the thought would be if someone's on a drug, these are expensive, but if you're on a drug and you're using it for weight loss, that over some course of time, there's going to be cost offsets. There may be less knee replacements. There could be, lower complications from osteoarthritis. There could be maybe lower risks or lower number of heart attacks. There could be other, benefits in terms of, right, weight loss is going to lead to, lower blood pressure. Maybe that's decreased stroke risk, right? So all of these things, can would be benefits of someone who's obese and losing weight. And so what they looked at was what were the outcomes at 2 years. Now these products, are relatively newer, minus the original Saxenda, which isn't really used often. So, in the perfect world, we'd like to see the outcomes at 5 years or 10 years. We just don't have that data yet. So they looked at 2 years. What they found was that 85% of people discontinued therapy at the 2-year mark. It's pretty significant, right? Think about that. 85% of people that are starting a GLP-1 drug for weight loss at 2 years had discontinued. Again, lots of reasons why they could have discontinued. Some of that may be that they lost the weight that they wanted and they're going to now manage through lifestyle and exercise and healthy diet. That's not a bad thing. 26% switched GLP-1 drugs during therapy, just a notable thing there. Some of that could have been due to product shortages, which fortunately at this point have calmed down a bit. But what they found was that the GLP-1 weight loss treatment was not associated with lower costs or medical events, which is interesting because you think that, right, there's lots of benefits of losing weight in those who are obese. But we just didn't see it, or at least they didn't see it when they looked at the data at 2 years. My personal thoughts on this is that, 2 years, probably not long enough. You're probably going to need to see 5, 6, 7 years worth of data to see, are we actually lowering the cost curve, or the trend? And we just haven't seen it yet. Again, the drugs haven't been approved long enough. Another organization, Blue Health Intelligence, they looked at some real world trends in GLP-1 treatment. They found that over 30% dropped out in the first 4 weeks, relatively similar to what we saw in our Horizon data. They found that younger patients were more likely to drop out. And perhaps not surprisingly, regular visits to healthcare providers improved the persistency or use of GLP-1 drugs. And I think we see that in many cases as well. People who are more likely to follow up with their healthcare providers in general are going to be more adherent. And they also found that people who had health inequities were less likely to complete 12 weeks of treatment. What I put here are really some headlines of GLP-1 drugs, and a lot of these were over the past month or so. And so, like I said, there's a lot of research being done, a lot of academic research. And I think the takeaway would be that, we're still studying a lot of this. And, you can see here that, GLP-1s have been tied to lower brain inflammation, but higher depression risk, right? Does that mean that GLP-1s cause depression? No, it just means that they found a link. It needs to be studied further. Around muscle loss, they found that Ozempic and Wegovy can curb alcohol addiction, right? That's very interesting. Probably going to be something that's studied, and they're going to, manufacturers are going to do bigger studies to see, is this actually, is there some type of, potential use of these drugs in alcohol addiction, right? At this point, we don't know, but some of the initial studies, the data does look positive. A lot has been around compounded GLP-1s. So for me, I take New Jersey Transit when I'm in the office, and all the times I see the ads for the compounded GLP-1s. And, it's, I would say, a hot topic. And while some of these products were under shortage, I think there's, some of these companies have popped up compounding GLP-1 drugs, and, there wasn't a lot of scrutiny around it because, the manufacturers couldn't keep up with demand. Now that some of those shortages have started to subside, I think the FDA is going to go on this a little bit harder. Um, the compounded GLP-1s are lower cost, but they may not have been manufactured in sterile conditions, or they may have safety risks, or you may not know exactly what you're getting because a lot of these are unlicensed organizations doing it. And then you can see some of the other things here that you can read in terms of other impacts or things of GLP-1s in the headlines. One of the other really notable things with GLP-1s is that there are a lot of other GLP-1 drugs in the pipeline, meaning the late stages of clinical trials from the pharmaceutical companies. And the GLP-1 drugs that we have today, specifically for weight loss, on average, they lead to around, at least the studies have weight loss that ranges from 5 to 15%. But there's newer drugs that are being studied that actually may be even more effective than the drugs that we have now. Some of these are combination drugs, and you can see when you just look at the class, these are GLP-1 drugs and something else. Some of these are, we're maybe a year or a year and a half away. But some of these have data that actually suggests it may be a little bit more effective. So it's an interesting, consideration in that, we have, a handful of drugs today for weight loss of these GLP-1 drugs. But there's going to be new ones coming, and these new ones coming may be more effective. We, have to see until all the data comes out. And these ultimately they'll have to get FDA approval and be shown to be safe and effective. But they may be actually more effective, which is encouraging, but it's something that's certainly notable. The other aspect of GLP-1 drugs is that there's a lot of the existing drugs that are on the market today being studied for other indications. And so this looks at potential label expansions for GLP-1 drugs through 2029. So these GLP-1 drugs are being studied for things like liver disease, kidney disease, heart failure, Alzheimer's disease, diabetic retinopathy. They're also being studied in pre-diabetes. And so it doesn't mean that all of these drugs are going to get approved, within these timeframes. They're going to have to go through the clinical studies and show they're safe and effective. But really notable in that today we have GLP-1s for diabetes, weight loss, cardiovascular disease, sleep apnea. By 2027, 2028, the number of use cases or indications could double. And that means that these drugs would have wider utility, as they get an expanded indication. So certainly something to keep an eye on, something at Horizon, we're continuing to monitor, working with these companies to understand. And you can see, when you look at the manufacturers, a lot of this is Novo and Eli Lilly. They have, some of the main products here. But there's even others that aren't even listed here. And if you go 2030 out, there could be other use cases as well. So something to keep an eye on, and probably some of this will be headline news if they get approval for some of these other indications. I'll pause if any questions on GLP-1 drugs. I don't see anything in the chat, so I'll go on. I think we're doing good with time. The GLP-1 drugs were kind of the bulk of what we had wanted to cover. And I want to transition now to specialty drugs. And specialty drugs, right, if you're not familiar, well, what does it mean for a drug to be specialty? These are really prescription drugs that treat rare, complex, and chronic health conditions, and they tend to be associated with a high cost. Specialty drugs has seen tremendous growth over the years. When you look at where we are today versus where we were, a decade or several decades ago, back in 1990, we had 10 specialty drugs in the market. It made up less than 1% of total drug spend was specialty related. And over the course of time, right, 2005, 2012, 2018, 2024, today we have over 700 specialty drugs in the market, makes up about 50 to 55%, depending on the data set you're looking at, of total drug spend. And I mentioned earlier, you may have heard it earlier, it's only about 2% of the drugs by volume. So they're just really high cost drugs that by nature of being high cost are making up a large portion of what we spend on specialty drugs. So I might be thinking, well, why are we seeing these big increases in specialty trend, right? There's new drug approvals, but are we diagnosing more people with maybe rheumatoid arthritis today, as an example, than we were, a decade ago? The answer, probably not to a huge appreciable degree. There's really two things that are happening. We're seeing new drugs and we're seeing just increased utilization. And so This slide's looking at the number of FDA drug approvals from 2009 to 2024 and with a projection for 2025. And if you go back into specialties in blue, to traditional or the non-specialty drugs are in orange, you go back to 2009 to 2015, 2016, pretty similar. It's really in that 2017, 2018 timeframe where you can see that huge divide where the number of specialty drugs are outpacing the number of non-specialty drugs by 3 to 4 to 1. Back in 2023, we had the highest ever at 59 approvals. And when you think about it, you don't really hear about many new antibiotics, antibiotics being a non-specialty or a traditional drug, but you don't hear about many new antibiotics being approved per year. You don't really hear about many new blood pressure medications being approved. It's really innovation, the R&D, research and development from the pharmaceutical companies are really in the specialty space. A lot of it is oncology. A lot of it is around rare disease and other autoimmune conditions. And it's not a bad thing. It's actually very exciting from an innovation perspective. It's just kind of interesting dynamic of where you see drugs being studied in clinical trials are more in this high-cost specialty space. The other example that we see happening is around utilization. So a lot of these specialty drugs are just being used more. And there's a couple of reasons for that. We're seeing one, more expanded drug indication. So, you may see a drug that gets approved by the FDA for one specific indication, and then the manufacturer does additional studies, and it gets approved for additional indications. Example there is if anyone's heard of Keytruda for pembrolizumab or seen the commercial for it. It was approved in 2014 for one type of cancer. If you look at the labeling today, it's over 40 cancer indications. Not a bad thing. It just means a drug like Keytruda will be used way more today than it was a decade ago. We're also seeing increase in add-on therapies or more combination therapies. So rather than some of these specialty drugs replacing older ones, there's been an increase in add-on therapies, which can improve clinical outcomes. That's the goal of what we're trying to do. Just means that they're going to be used more, and we're going to see more utilization and higher costs. And then lastly, increasing survival. So in some of these conditions, as we're bringing really effective specialty drugs to market, people are living longer. And as people live longer, they're going to be on therapy longer. Sometimes for conditions where there was no medications available. And you can see a few examples there. Some of the other really big things in the world of specialty pharmacy are listed here. Actually, there's really four of the big trends that are going to be seen industry-wide. And the first is going to be around cell and gene therapy, where today we had 15 products approved since 2022. These are really interesting in how they work. We won't get into all the details just in the interest of time. But these gene therapies are designed to be curative. They may not be effective in everyone, but they're designed to be curative. So they're a one-time infusion, and they're designed to get to the genetic cause of disease. And so if you have a gene that's coding for the wrong protein and that's causing disease, there are, in some cases, gene therapies that can cure that, right? It puts the right protein in, codes for the correct right gene, codes for the right protein, oversimplifying it, but these are potentially curative. There's, again, 15 products since 22, I think total are a little over 20, but there are thousands of these in development. And really, almost every rare disease that has a genetic component has gene therapies being studied for it. So for things like cystic fibrosis and Huntington's disease and ALS and Pompe disease, different types of retinal diseases, cancers, there's gene therapies being studied that potentially could be curative. Doesn't mean that all of them are going to get approved. They're going to have to go through the process of getting FDA approval. The other thing to note is that these are pretty expensive. So these are in the $2 to $3 to $4 million range. We have one of these products that's $4.25 million. So quite costly. Oncology drugs, we're seeing huge increases in the number of oncology drugs in late stage development of clinical trials. Seeing a 60% increase from the prior decade. We're seeing way more innovation in this space, and we're seeing improved outcomes. Also, if we were to go back over the last 10 to 20 years, outcomes in many types of cancer have improved. Survival has improved. Outcomes have improved. So a lot of innovation, a lot of reason to be excited for what's going on here. Orphan and rare diseases, again, seeing increases here. What I want to focus, though, is on biosimilars, and I'll really wrap up the next few slides on biosimilars, where if you don't know what a biosimilar is, maybe you never heard of a biosimilar, it's kind of like a generic drug. You could think of it that way. It's a lower cost version of a higher cost drug. It's kind of a separate pathway of what the FDA considers to be a biologic and a biosimilar. Just think of it as a lower cost version of some type of biologic drug. And we had a record 18 approvals in 2024. Currently, we have 69 biosimilars that have been approved by the FDA. We got a little bit later start in the US than Europe and other parts of the world in getting these products to market, but we're starting to catch up. We had Humira biosimilars, if anyone's heard of Humira, an autoimmune drug, in 2023, Stelara in 2024. And the value of the biosimilar market, even though we got a later start, it's expected to triple by 2030. So as drugs lose their exclusivity periods and their patents come up and their patents expire, other pharmaceutical companies can bring in these lower cost biosimilars. So where are we today with biosimilars? 69 have been approved by the FDA, 45 are currently commercially available. That spans 5 categories from autoimmune, oncology support, eye disorders, and diabetes. I won't go through all of these, just know that there's biosimilars out there. They are being used when you look at the national data. Some of these are being used more than others. Some of these have market shares of biosimilars in the high 90s. Some of them are a little bit straggling behind, but overall, these are being used and they're lower cost, right? They're kind of a similar version, a lower cost, a generic version in that sense. They're going to be lower cost. So that's a good thing, right? As drugs lose their exclusivity period, we see more of these lower cost drugs. That's good for everyone, right? It's just going to lower costs. It's going to lower out-of-pocket costs for patients. And it's going to lower costs for the healthcare system as a whole. The value of the biosimilar market, as I mentioned earlier, is expected to triple by 2030. Listed here, again, not going to go into all these drugs, but these are really possible launch dates of a handful of biosimilar drugs through 2029. And some of these are pretty big. Like if I were to, if we were to go through each of these, some of these represents several billion dollars in sales. Many of these are multi-billion-dollar sales drugs in the US. And so if we're able to bring lower cost versions of these drugs, that's a positive. We're able to drive down healthcare costs. They're just as equally safe and effective, and that's a net positive. So I'll wrap up. We wanted to leave about 10 minutes for Q&A. So if I just had to summarize everything I said, or if you didn't listen to anything and you get the summary here, what I would say is that the 4 important points are: one, that GLP-1 drugs, these are really effective drugs, right? They work really well, whether it's for type 2 diabetes or weight loss, sleep apnea, cardiovascular disease. They work really, really well. But there's concerns around safety and affordability. And, I think there's a sentiment that if the manufacturers had priced these drugs at like a third of the cost, then, it would be much different than where we are today, where the cost is fairly high. And you have, employers and payers saying, like, how do we manage the appropriate use of these drugs? And that's where the kind of the prior auth come in. They're expensive drugs, but they work really well. So it's trying to that balancing of drugs that work really well, but they're also really expensive. 2, research is ongoing to understand long-term outcomes of GLP-1 drugs, right? The data that we have today doesn't really show that there's any cost offsets for GLP-1 drugs, but it's still early. And we also know that spend will continue to increase with future label expansions. And so today there's 4. If these were found to be effective in prediabetes, that would expand the patient population quite a bit. Just like if they were found to be very effective in Alzheimer's disease, that would expand the patient population pretty significantly. Now, we don't know that. We'll have to see from the clinical data once the manufacturers run those studies. 3, specialty drug category. It's seen big growth in recent years, and it's continued to increase due to the robust pipeline of drugs in late-stage clinical trials, and also just increasing utilization for the reasons that we mentioned around more combination therapies and more approvals. And then lastly, oncology, rare disease, and cell and gene therapies are going to continue to drive up specialty drug costs. But on that flip side, biosimilars also offer cost relief. They're lower cost versions, kind of these generic versions that are going to be lower costs and going to offer some affordability within the healthcare system.
Hey, Tim, I just wanted to point
Oh,
out
go
there
ahead.
was a question about covering compounded GLP-1s that came in on the chat.
Yes, I do see that. Our plan's covering compounded GLP-1. So the answer to that is no. We don't at Horizon, to my knowledge. I'm not aware of any payers, blues or non-blues, that are going to cover compounded GLP-1s. And the reason is that they're not approved products. What these compounding pharmacies are doing is that they're buying bulk powder from different parts of the world. They're buying the bulk ingredient and they're kind of compounding it and making it themselves. And in many cases, they're not licensed, they're not approved. The FDA, from what I've heard, is that they're going to be cracking down on this. They're going to be doing, essentially going in and shutting some of these compounding places down. And, they are offering it at a lower cost. But there could be some safety concerns. And I don't think there's really a lot of data on, are compounded GLP-1s as safe. But if the inference would be if they're not licensed or they're not approved or they haven't gone through the necessary certifications to be able to compound these drugs, then there could be some safety risks. So no, they're compounded GLP-1s. They're non-approved products, and they would not be covered.
And I think for a brief period, maybe the FDA was allowing the compounding while there was significant shortages on some of those. That's my recollection, but that's since now been resolved. So it's now they're no longer allowed to be doing that. Is what I understand. Any other questions?
Tim, I thought what you were saying about these drugs have been in place, the GLP-1s, for 2 years, and we haven't seen the benefit of these drugs really overall for the cost. And I think I heard you say it's closer to 5, 6, or 7 years where we'll really have an understanding of what that means for the healthcare system as a whole. Who would be, the leader in terms of releasing that data? Are these individual studies done by doctors or providers or health plans? Like, who is who is going to look at that? Who's going to decide that?
Yeah, I think it could be twofold. And I do in that 5, 6 years, that was just kind of my inference, my own kind of clinical opinion. I think on the one hand, the pharmaceutical companies are definitely going to be studying these products long term, because if they can show that there's um maybe, let's say, a survival benefit, like if we can reduce the risk of heart attacks over 5 years, that's a huge selling point for the pharmaceutical companies, right? They can really manufacture that and sell that in a little bit of a different way. So I do suspect, and they have long-term studies going, so I suspect that they'll be looking at that over the course of time. Other than that, though, it's going to be a lot of the people doing the research on this is going to be those with access to the data, and so that means providers and provider groups probably not, but health plans absolutely. And so we have lots of data at Horizon. We've been looking at this in our data as well. For example, we're looking at the persistency data, and I think over the course of time could be looking at the long-term data as well. I mentioned the data from Prime Therapeutics. They are a pharmacy benefit manager with access to lots of data. And so that's where I think we'll be seeing it. And probably, I wouldn't be surprised if, CVS and Optum and United and Cigna, right, all these other organizations, they're probably looking at their data as well, to see, are there cost offsets? Because again, that's the question, right? If you're going to pay 18, 15, $16,000 a year for these drugs, someone's going to lose weight, and that's great. But the question that we're getting is, well, is there cost offsets for that? Are we paying more on the pharmacy side, but then going to pay less on the medical side? And that's the hope. Data just isn't quite there yet.
Thank you. The other question I had was on biosimilars. So the individual drug has to expire, right, on the patent before these companies can begin making a biosimilar. So are there drug companies that are solely focused on biosimilars, or like a Novo? They're producing, I think I saw Wegovy and Ozempic, right? They're makers and inventors of that essentially. Are they also, producing biosimilars on other drugs that are expiring, or are there like really specific biosimilar drug companies?
Yeah, so it's actually both. So there are some companies that specialize just in biosimilars. Like, for example, Fresenius Kabi, they're a big one in biosimilars. They have lots of products, lots of biosimilars currently available in those that they're studying. Then you also see like Pfizer, where Pfizer produces biosimilars, and they also make some of these non-biosimilars. So it's just kind of a mix. I think they're looking at it from the perspective of, where can we where can we make money on this? So we see both would be the answer.
And I'll just add too, that's a little bit of a departure or difference when you compare that to, like the older type medications where you had generics, the more the tablet kinds of things, where the margins were probably just not there. So the brand manufacturers kind of stayed away for the most part. They didn't really dabble in the generics, but then you had companies like Teva that really focused in on generic products. But this is a departure, as Tim said. I mean, the dollars are just so huge. Right? Humira was $20 billion in sales every year. So there's huge opportunity. So even some of the traditionally brand manufacturers are jumping in to make some biosimilars because there's money to be made.
And we're also seeing if you're a manufacturer and your patent's expiring and you know that biosimilars, companies are going to be bringing biosimilars, they're pretty creative in terms of, exerting their patents. And it's probably just speaks to the US where the number of patents, like for Humira, I think the manufacturer AbbVie has around 6 times the number of patents on Humira in the US than they do in Europe. And so what that means is that we have the degree of competition is slower in the US. And so for Humira, which is a good example, that was approved by the FDA, the Humira biosimilars were approved by the FDA in 2016, but we didn't actually see them hit the market until 2023. And there's other examples where Enbrel, the Enbrel had biosimilars approved in 2016. We're not going to see on the market commercially available until 2028. So, a lot of these have gotten caught up in patent litigation issues, settlement agreements. Some of these have made their way through the court system up to the Supreme Court. So it's a hot topic. It speaks a lot to the system. I think people would say, not in the pharmaceutical industry, but outside of the pharmaceutical industry, people would say that, there's this misuse of patents and it delays competition and it delays lower cost drugs. Because, if you have 200 patents on a drug, it's like you can just play the game all day to say, hold on, this biosimilar company is infringing on patent, 34-201, for example, and then, goes to the court system and it goes, through it, which can delay it. And so there's been a lot that has been proposed from a, reform perspective around patents and, the timing of exclusivity. Will anything change? Don't know, but there's a lot of efforts to keep similars away from the companies that have these products where biosimilars are coming. They're making a lot of money on it. They're trying to keep their sales.
And I'll just add, Joe, when you asked the question, it's not as simple as, the patent expired. Once the patent expires, a competing manufacturer, generic house or whoever, they need to successfully sue to bring a lawsuit to be allowed to make the drug, even though the patent expired. So it gets all caught up in the legal system. So it's very very complicated, and I'm sure it's by design.
I think we're about 1 minute over. Michael, I'll turn it back to you.
Thank you so much, Timothy. Joe, Michael, thank you as well. Lou, I'll pass it one more. I mean, do you want to make any final comments?
No, I'll tell you the one thing that I find interesting on the data is persistency. For some reason, I don't.
Hold on one second, Lou. Is that just me, or is everyone hearing that? The echo.
I hear a bit of an echo as well.
Okay, Lou, do you have multiple screens open? Just making sure. Do you get your final word in? Yeah, major echo.
Do you still hear an echo?
Yeah.
Okay.
Let's give that a go.
How about now?
So it's still there, but go ahead, Lou.
Okay. So anyway, just the persistency thing really fascinates me. Of people who go on these drugs and then come off them, but we're still seeing sharp increases. So I guess with new prescribers. So that's all. Thank you, everyone. Sorry for the echo.
No worries. Technology happens. Thank you so much, Lou. Again, Timothy, thank you so much for a really informative session. Joe, Michael, thank you as well. For all the attendees live here this afternoon, thank you so much for your interest in our content. Thank you so much for joining us live. Because you are here live here today and stay for the duration of the presentation, you will be receiving 1 Board Member Academy credit that will be reflected on your transcript. Again, just give us a couple business days due to it being a manual process on our end. We will have this slide deck available as a resource up on the SWUGO site, the webinar conference site. So we definitely encourage you to view that, share it with your district, share it with other district leaders in your schools, on your board, in your district. And the recording will be up later today on our webinar page. If you go to our ngsba.org webpage under the trainings tab, click webinars. That's where you'll see all of our previous webinars, along with this one, and a lot of great ones upcoming as well. Thanks again to everyone here today. Thanks to Brown and Brown, and thank you. So I hope everyone has a great rest of their day. We will meet back here. I think next week we have another webinar, so definitely check the schedule, and we will see you very, very soon. Thank you all so much, and have a